Okay. Thank you. Thanks, everybody. Thanks for the invitation and the opportunity to tell you a little bit about the work we do and how it could actually, hopefully, be helpful for you here in South Carolina. I'm right now in Canada, in Vancouver, and the BC Cancer Research Institute, where I spent 11 years before at the University of Michigan School of Public Health. And I'm part of a consortium of investigators funded by the National Cancer Institute here in the US. So I'll focus the conversation or presentation on what has been the impact or some of the impact that has been already highlighted of tobacco interventions on tobacco use and overall on lung cancer morbidity and mortality. I'll tell you a little bit and just after an introduction, just show you some trends of smoking and vaping in the US, so put things in perspective and then maybe help with the conversations that are happening already, and then talked about the impact of tobacco control on lung cancer mortality reductions, so you know how much impact you all have had to date, and then talk about two examples of the work that we do, I guess complementary to what was presented before, to measure the impact of new and potential new interventions to reduce the burden of tobacco in general, overall, and lung cancer in particular. I'll focus on lung cancer because that's a lot of the work we do, but really we're talking about all tobacco-related mortality. And I'll just do a brief intro, and you all know this. We've known that tobacco is harmful, and we've known for that for many years, since the 1950s. And we had the Surgeon General report in 1964, and tobacco control emerged out of that. And really there's been a lot of progress with smoking decreasing considerably in the US, and in particular lung cancer rates have followed. But we're still at 11%. Oops, sorry, that should have said 11%. And smoking, of course, remains the top preventable cause of cancer and death, and top cancer killer in the case of lung cancer in the US and globally. These are just data showing how far we've come back from the 60s. This is an older figure. And if you look at the more recent years, this is data from the NHIS, National Health Interview Survey, you see that smoking continues to decrease. But it's not as let's say, homogeneous as one would like, and we'll see what I mean by that. As smoking went down, lung cancer mortality came down. The red line there, this is very nice data by the American Cancer Society that show how lung cancer came from nowhere to be the top cancer killer in both men and women. Now it's coming down. That's great. And both in men, for women it took longer, but now it's also coming down. So how much can we attribute, for instance, of that decrease of lung cancer to tobacco control? So we published a study, a modeling study. What I do most of the time is models, projections, simulations, and in collaboration with people at the National Cancer Institute, we made projections of how much of the cancer deaths could be attributed to different prevention strategies and screening as well as treatment. And basically, I'll show you a little more later, but the bottom line is that there was cancer prevention and screening account for the most cancer deaths averted for 5 major cancers. And among those, 3.4 million lung cancer deaths were avoided during that period. Most of them, 98%, due to tobacco control. So the lion's share of that decrease has been thanks to the reductions in smoking. More on that later. So things appear to be going well, but as you know, there are many challenges, and particularly tobacco and lung cancer disparities persist, being one major challenge. Higher incidence in certain population groups, disparities not only in tobacco use, but also in exposure to other relevant risk factors, and pollution being one of them. Now that you have lung cancer screening, and I'll mention about it later, not everyone is getting access, and there's, again, disparities emerging in access. And of course, there's disparities in healthcare access across the board. It's not only about, I guess, the traditional socioeconomic haplogroup that we think about, there's a very simple dynamic that, or I guess simple in the sense of trying to what it means, which there are differences by age in what's happening with regards to the reductions in smoking. And what these figures show, and is recent data from National Health Interview Survey as well, which just simply look at prevalence by age group. And what you see is that that decrease that we're seeing in recent years is not occurring across the board. It's mainly occurring in younger people, so that's great. I think we should also be super happy about that. Smoking is really collapsing among younger folks, but it's flat in older adults. And that's where there's sort of a big mismatch in terms of the conversations and things that we're saying, right? We have a lot of things to celebrate, but we have a lot of things to be concerned about, because the people who are, I guess, at the ages where the rates of chronic diseases, cancer, and others are more common, are the folks that are not quitting, and that's something we need to work on. There, of course, are other challenges and emerging, and I think tobacco products are changing. There's e-cigarettes, and we've talked already a lot about that today. Oral nicotine products, there'll be heat and not burn products soon in the US, and there are uncertainties about what these products do. Do they lead to more smoking or not? Apparently not. But of course, they have their own health effects. We believe they probably are lower, likely much lower, but we don't know exactly by how much, and so we need more research in that space. So to put things in context and just complement what I just showed, so who is vaping and smoking? And I'll just focus on age patterns. This is for the whole US. I didn't, I guess, was able to produce these figures for South Carolina. I will do and share those if anyone is interested. For the meantime, this is for the whole US before we get into South Carolina. So first, youth use, and to many of you, this will not be new. This is data from the National Youth Tobacco Survey based on past 30 days use reported for e-cigarette and cigarette. And for cigarettes, we also, I guess, slightly different than what CDC does, we added the constraint of them reporting having smoked at least 100 cigarettes, which is to make the data more comparable with adults. So the good news, and I guess the super good news, is that among adolescents in the US, and of course there's going to be variability across states and things like that, but for the most part, smoking has collapsed, you can call it. Under these definitions, it's under 1% for both males and females in 2023. The 2024 numbers, the public data is still not available, so I cannot tell you exactly if they remain or they were slightly lower. When you don't do the 100 cigarette criteria, there was still a decrease from 2023 and 2024. So hopefully that's the case. So smoking, great, seems not to be an issue. Of course, we want things to keep and remain like that. How about e-cigarettes? And so for e-cigarettes, it's past 30-day use, it's high school, and we know sort of what happened. The e-cigs came out and suddenly started to become popular or common, at least reported past 30-day use among adolescents, reached a peak, the products probably not that good, that appealing, came down. Then the products became better in attracting people, including adolescents, and maybe the Juul phenomena, and other products lead to an increase. But then there was a peak, response, public health, the valley scare, and changes in perceptions. And now we're seeing them come down, and I think the prevalence in 2024 is actually lower. So yes, a lot of concern about E6 there. I don't know, I mean, still concerned, I would say, but things are much more different, right? And for the terms it said that there was an e-cigarette epidemic. I don't think that's an appropriate term anymore. We'll see where this goes. I mean, maybe they are just coming back to a natural progression. We'll need to figure that out. And I guess we need more time. 2024, they went down even more. Still, that publicly available data is not there, so I was not able to include it in the figure. So who is, among those who use e-cigarettes, who are they? And turns out that the majority now are never smokers under this definition, or kids who have never smoked. So we went back in the day to where kids who were reporting e-cigarette use were predominantly current or former cigarette users, now they're predominantly, I guess, never cigarette users. Not surprisingly, almost none of them is smoking. So it's not surprising that now, if they use e-cigarettes, more likely they're also not smoking. So it's really a change of the profile, and I guess now we're going to probably start seeing cohorts or generations of young kids that maybe go into adulthood and they vape but never smoke. And that certainly will bring some interesting questions and, I guess, motivations for research. This is a summary of what I just said. Lots of data in adolescents, not so much data among adults until recently in terms of e-cigarette use. So let's look at some adult data before we go into other things. This is data from the National Health Interview Survey, current everyday or someday for both products, cigarettes and e-cigarettes, and with cigarettes having the additional condition that they had to report smoking at least 100 cigarettes during their lifetime. We saw that figure before, general decrease in smoking in US adults, and it's getting to about 11%, and probably it's going to continue coming down. What about e-cigarettes? It was relatively flat until recently, where we now start seeing more progressive increases in e-cigarette use among US adults. This is 18 plus. And again, the 24 numbers are not there, but we expect them to be slightly higher, not much higher. But, so they're not like exploding in terms of use. But again, things are not consistent across ages. Among younger adults, 18 to 24, we see a very rapid decrease in smoking, and both in young males and young females. And at the same time, we're seeing a much faster increase relative to the overall trend of e-cigarette use. I guess there was a decrease in the last time point. We'll see where 2024 is. But certainly, there is sort of like opposing trends. Not making any conclusions that this may be causal from one or the other. Simply, that's what I guess the data is reporting. And one product is really going down in young adults. The other one is going up. There is relationship between these, and certainly one can expect that one is affecting the other. As we go to the next age group, still strong decrease in smoking, 25 to 34, and similarly now we see an increase in vaping in this group, at least current report of use. We're not looking at intensity or levels, this is just who are using or not. As we go to other groups, you see that the smoking trends start flattening, so the decrease is lower. And that's not good, right? That's not something we want to do. We sort of see relatively flat trends of e-cigarette use until more recently, much, much lower use than the previous groups. As we go to older groups, decrease, but still relatively slow, flat for e-cigarettes. Maybe start to see a little bit of an increase there, but not much. 55 to 64, very unfortunate, flat for smoking. Not much use of e-cigarette use. And 65 plus, flat, like it's almost horizontal, and almost no use of e-cigarette. So some observations is that we can see sort of these age patterns where as you look at older age groups, the decreases in cigarettes slow down, and as you look at e-cigarettes, as you look at other groups, the increases in e-cigarettes slow down. So it's almost like a tale of two populations. Smoking prevalence continues to decrease, but the decrease is primarily driven by younger adults. That's good for the long term. Long term, probably we're going to be fine, but there's a lot of people who are still smoking, and you're here for a reason. We need to do something about it. There are big decreases among adolescents and younger adults among smoking. E-cigarette use prevalence slowly but progressively increasing. Most increases are occurring among younger adults. And in younger adults, an increasing proportion of e-cigarette users have never smoked cigarettes. I show you for youth, if we look at the same thing for younger adults, you see progressive increasing that those who report using e-cigs are never, or people who never use cigarettes. So that's the status, that's where we are, and I think that's what we need to work with right now. Okay, so I'll switch gears a little bit in the minutes that I have left, just to tell you a little bit of some of the things we've done. I really appreciated the previous presentation that shows some of the projections that people here at the University of South Carolina have been doing in terms of the burden, in this case, in their case of smoke, I guess secondhand tobacco, and because it's important to quantify things and to make projections and estimations of what's the impact that some of these interventions have had. So the type of work that I do, that I largely talk about it as simulation modeling, is something that has been around in public health for many years, and that help us try to understand what are the so what of many of the things that we do. And long history in infectious diseases, COVID, lots of models you saw, even the White House presentations, you would see reports of projections of models of what was going to happen. But these type of models are also and have been around also in tobacco control for many years. Within that, I'm part of a consortium funded by the National Cancer Institute called the Cancer Intervention and Surveillance Modeling Network, or CISNET, which is an NCI-sponsored consortium of modelers, statisticians, econometricians, mathematicians like myself, that we try to create simulations of risk factors, disease, in this case cancer disease, and then the impact of policies on prevention and control of those cancers. There work on multiple cancers. I particularly work on lung cancer, and you can learn more on our website. Within the CISNET Lung Working Group, which is the one that I have the privilege of leading, we have multiple models at multiple institutions in the US and elsewhere, where we develop these models to make projections and try to, for instance, a lot of the work that we've done, what has happened with smoking, and how does that translate into reductions, for the most part now, on lung cancer rates and risk, and what's been the impact of other tobacco control policies on that. And we've done a lot of work with lung cancer screening. What could be the impact of screening if we were to adopt it? And do projections of what the trial said that would be the mortality reduction to what the impact would be at the population level. So we actually work with the US Preventive Services Task Force to basically do that. Okay, so what if we implement screening for certain groups? What is the potential impact? So we made those analyses to help them back in 2013 with the first recommendation for lung screening, and more recently in 2021 with their updates where they expanded the eligibility. And those decisions were partially informed by modeling that we did for them, and that was published with the recommendations showing our analysis. I won't spend too much time on that, but encourage you to take a look if you're interested, and happy to talk and share more information. So that's what CISNET is, and I mentioned before, CISNET is a resource. I guess we're modelers, we're grant funded, but we are available to the NCI to do projections and analysis. So recently they call and say, we're really interested to know how much prevention has contributed in the decrease of cancer mortality, and as opposed to things that maybe are more at the later stage, like treatment improvements. And so we worked with the leadership to do this type of analysis. We did those for 5 cancers. I particularly work on the lung cancer projections, but they were done also for breast, cervical, colon, prostate, and lung. So our goal was to project lung cancer mortality using our models as it happened, so what we can reproduce reality and how it happened, and then project what would have happened under a counterfactual scenario, that we would have never figured out that smoking was bad. So we never realized that smoking was bad. There's no tobacco control. There's no this meeting. So it is an alternative universe, if you want to think of multiverse, like in Marvel, where you're all not here. You're doing something else. You're probably still in public health, but working on other issues. So in that world, we want to know what is going to be, or what was the benefit of actually knowing, figuring out that smoking was bad and doing something about it. So that was the goal. We had done similar exercise before to update that through 2020 and come up with some projections to help the leadership. when I say we do modeling and projections, just briefly, one of the things that we do is figure out what did people do in terms of their smoking behaviors, how early they started smoking, when they quit it, and come up that what we call probabilities of smoking initiation, probabilities of smoking cessation, probabilities of how that people will smoke more versus less cigarettes. And we take that data that we estimate from national surveys, as well as mortality from national surveys, by generations or per cohorts, and we put it in a simulator, which is basically a computer program that we ask, and then it simulates an individual and what happens with regards to their smoking, and then we use that to simulate then what would happen to that person with regards to lung cancer. Maybe they get it, maybe they don't, and so we account for all, I guess, probabilities for those events. So we have what we call the actual tobacco control. This shows generations or birth cohorts and how smoking, let's say for males and females, changed for different generations. For males, coming down from the 1910, this is age-specific smoking prevalence, and eventually going down. For female, actually, it increased up to the 1930, 1940, not shown here, per cohort, and then eventually came down. So that's what actually happened. And these are, I guess, model estimates, but based on hard data. And we have estimates for South Carolina, if you're interested. And then we have the no tobacco control, the counterfactual, the alternative universe. So here in this universe, smoking was never found to be bad, so smoking prevalence among males remained at its peak. Among females, it actually increased from where it was because there was an increasing trend, and we came up with scenarios that say, okay, it would be reasonable to think that we had peaked at that level, and that's what we did. So then, under these scenarios, then the question is, how many people died from lung cancer in this scenario, and how many people would have died from lung cancer in this scenario? Compare the difference, and you have how many people you prevented from dying from lung cancer. Which is that what they did. We use two CISNET models. In CISNET, we use multiple models, multiple institutions. We allow for the fact that modeling is a subjective exercise, and so that bringing multiple modeling teams to ask or look at the same question allow us to bring some of those uncertainties and cover those. So we use two models. Here at the bottom, you see the observed data, what the models predict with regards to age-adjusted lung cancer mortality for both males and females. And then what the models predict would have happened in that counterfactual. You see the models are not on top of each other, and that's okay. We are allowing, the models are different, they use different assumptions, they have different data that inform them. So their projections differ, but overall they tell the same story, although it's a different quantitative story. That's with regards to lung cancer mortality. It's a much higher mortality we would have expected under the counterfactual, much more lung cancer deaths. How many? By the end of the period overall, one model said we probably prevented about 2.6 million deaths. The other one said, actually much more, I guess, optimistic, we prevented about 4.1 million deaths. There's variability, and again, it's okay. There's uncertainty around these things. There's not that alternative universe. We're just making it up in a computer. So then the people at NCI took our projections, then translated them, and made their own calculations, and came up with an estimate of 3.39 million deaths averted due to tobacco control. Separately, they estimated that advancements in treatment for lung cancer that hasn't been that effective until recently have saved about 60,000 deaths in the US. Screening was not considered for lung cancer because it's too soon for it to have an impact, measurable impact, so it was not looked at. So a total of 3.45 million deaths averted. That's a 62% reduction of what it's projected that could have happened in that alternative universe where we never figured out smoking was bad. So 62% of all possible lung cancer deaths were prevented. And among those, as I mentioned, 98% are attributed to, this should be to tobacco control. So I guess kudos to all of you and kudos to everyone who has been here before, because there's been a remarkable decrease in lung cancer mortality, and the large majority of that, of course, has been due to tobacco control. There were projections for other cancers, breast, cervical, colon, prostate. For those, the projections are that the deaths averted are 2.49, so even less than what has been averted for long. And of those, 1.36 million due to prevention, which is about half. So really, tobacco control and lung cancer driving the lion's share of benefit from these 5 major cancers. Not all cancers, but it's like the 5 big ones. Let's put it like that. So conclusions of that work is that an estimated 6 million deaths were averted from these 5 major cancers combined, with prevention accounting for 8 to 10 deaths averted, varying by site, with lung having almost all being from tobacco control and prevention in this case. Screening were also a major contributor for the other cancers, but further mortality reductions are needed, and those will require increased use of effective interventions and new discoveries, of course. So we're not done. Tobacco control accounted for 3.4 million lung cancer deaths averted, which is about 57% of all deaths averted for these major cancers. So quite a big effect. Okay. The last thing I'll tell you. So in CISNET and in this work, we've done a lot of things for the US, and now we're moving forward to try to do things at the state level. Bring those models that we've developed using your dollars and all taxpayer dollars through the NCI and NIH to try to do work to support state cancer prevention and control. And within that, we've done 2 things, and I'll show you some results for South Carolina. So we've expanded our work to consider state-level models, doing what we did for the US. Estimate patterns of tobacco use by birth cohort for each of the 50 US states in the District of Columbia, mortality patterns, and then bring those into our models to do projections using our simulations. And there are 2 examples we have so far, one published, one which is still brewing, which is lung cancer screening. So I'll tell you about both right now. So I showed you this before. This is our simulator of the US population, and basically what we need to do is replace these US parameters with state-specific parameters. So we've done that. We did an analysis of the tobacco use supplement to the community population survey, so TUS-CPS, with NHIS to estimate initiation cessation probabilities for all the states by birth generation, by sex. You can look at those, you can go and browse them and look at them for your own state. I guess here you have an interest for South Carolina, and happy to share, and those are available. And we've published those. Then we also need mortality rates by generation. So we estimated mortality rates for each of the 50 states and DC, and we actually just published part of that work in JAMA Open Network, and there was a lot of interest because our cohort or analysis by generation show that, as you can see, as NBC News picked up, is that, for instance, life expectancy for women in some southern states has barely budged in more than 100 years. So there's comparison of how mortality has changed. Encourage you again to take a look at this paper and some of our specific mortality projections, and you'll find numbers for South Carolina. I didn't have the figure for South Carolina, so I'm sure California. We took all that data and then put it in our models, and the first thing we did is, well, tobacco 21. I know we're not talking about tobacco 21 here necessarily, but tobacco 21 has happened, and we wanted to know what is the impact of tobacco 21, not only the federal law that is now active, but previous state and local laws in different states. You see there South Carolina in terms of some projections. So I'll show you in a minute. So what we did is generate those parameters. It's step 2, actually. The first step, and I'll show you some numbers, we estimated the effects of T21 on smoking initiation, and we also, quantified when the policies, if any, at the local, state, and then federal level were implemented in each of the 50 states. And when people in those states started, what percentage of people were covered at different times. We put those into state models, and then we made projections of health outcomes, and then we put that into a decision tool that is publicly available. So briefly on those steps, we characterize and just gather all data of when tobacco 21 policies start coming up after the publication of the Institute of Medicine report, and then Hawaii being the first, and then California in terms of state. Eventually, to increasing the percentage of each population in each state covered until the federal law came. I think sadly, as far as I can tell from the data we had, South Carolina didn't have a local or state laws. It just began with the federal law. Lots of research has happened since T21 laws have come up, and research measuring what are the effects of these laws on reducing smoking initiation. We came up with some estimates of the policy based on the best available data, and then also made assumptions in terms of enforcement, and then came up with a range of effects that the policy would have that we put into the model. As I mentioned, for each state, you here see South Carolina. We had the history for each state of when local laws started to come here in green, state laws, and then federal in blue, state blue, and then federal in yellow. So yeah, South Carolina, like Wisconsin, didn't have anything until the federal law. And then we have those parameters. These are showing numbers, estimated smoking initiation probabilities and cessation for South Carolina with that policy coverage, and then projections of how many deaths are not prevented today. Tobacco 21, you're preventing kids from starting smoking. You're saving them from dying early 50, 60 years from now. So it's a hard thing to do because you really need to look very into the future of where the effect of this policy is going to be. So as you see, we did projections through 2100. And when we did that, then you can see for the different states, here's South Carolina, I think in the mid scenario, about 12,500 deaths are assumed that T21 federal in South Carolina is going to, I guess, premature deaths that it's going to prevent. And there's different scenarios. And of course, you can compare different states. Here on the left, absolute mortality reductions. Larger states have more people, so they have more deaths to prevent. So it's not necessarily fair. So we also looked at relative mortality reductions by state. In both metrics, South Carolina is sort of in the middle in terms of the benefit. And you see South Carolina is all red in both. That means it's all, the benefit is coming from the federal law. And the last thing is I just wanted to mention this and share with everyone and hope that it's helpful. These numbers for each state are part now of what we call our tobaccopolicyeffects.org or tobacco control policy tool that we've developed and that is available online and where you can get and see in more detail these estimates for the different states. We also have other policies. The projections for those are not as up to date as Tobacco 21. Now we're in the process of updating cigarette taxes. If you're interested in collaborating, we would be thrilled to be able to do so with you. Smoke-free laws as well, that also have percentage coverage, so we need to update that for all states, for South Carolina and another. Tobacco control expenditures was CDC, the CDC money flowing to the states. So this one would be interesting perhaps to model if that funding ends, what's going to be the impact. And we also have graphical warnings. So I encourage to take a look. All right, I feel like I have 5 minutes, I think, if I look at my counter. So I'll tell you one last thing that we did and that show you some numbers for South Carolina. So we really need older folks to quit smoking. So one opportunity that we have is we're bringing some people for screening. They're ever smokers. Some of them are currently smoking, and they're heavily or have smoked quite a bit. That's why they're eligible for lung screening. So it seems to be a good opportunity to bring people into cessation as well. So we are now creating models like we had for the US for each of the states for lung cancer screening impact. So we simulate individuals from each of the 50 states in DC, about 1 million men, 1 billion women. We have to do large numbers, so we didn't have much variability. For the birth cohorts from 1925 to 2005, to make projections of the impact of screening from 2015 to 2050. We're modeling uptake based on the numbers at the Behavioral Risk Factor Survey. As it's pretty low, the uptake, so we start there. And then we look at what happens if uptake increases. How many more people would you prevent from dying from lung cancer if you do screening and improve uptake? And here I'm just going to quickly compare California and South Carolina, where for South Carolina, we also added a one-time smoking cessation intervention with modest efficacy of 15% probability of quitting, to just see how are the combined effects. If you do not only do screening, but you do screening with cessation. Some projections, how many people are eligible for California. Percentage of the population 50 to 80 who are eligible, according to 2021 task force recommendation, will decrease. It's about a little under 1 million and decreasing in terms of proportion, about 7% in 2020. For South Carolina, we project, based on South Carolina data, that today there are about 400,000 people eligible for lung screening, according to task force recommendations, and that the number is not going to decrease. The proportion probably is going to decrease a little bit, but with population growth, you're going to stay at about 400,000 eligible, 200,000. I think it's 200,000 eligible. Sorry, I may have made a mistake. It's 200,000 eligible. We brought one of our simulation models. I'll just show it to you to make the point that we try to account for all the complexity of lung cancer in these models. Again, we try to simulate not only the types of lung cancer, stages of the lung cancer, survival for the lung cancer, and of course, if those occur according to how much an individual in the simulation smokes. And so the models take account for all this complexity and try to do this again, simulation. Here you see just quickly a couple of results. Decreases in lung cancer mortality in the absence of everything, smoking, tobacco control, still bringing lung cancer mortality in all places, including California and South Carolina. If you add screening, not everyone is eligible, 20% mortality reduction roughly, so it's not like a perfect solution. If you screen everybody in California, you see the decrease there relative to the baseline of age-adjusted lung cancer mortality. I apologize for the small fonts. For South Carolina, in terms of relative decrease, is much larger, right? You have more people eligible, so you're gonna bring down, if you implement screening and cover everybody. For South Carolina, the solid versus dash shows the effect of adding cessation on top of screening for this population. In terms of lung cancer, in age-adjusted rate doesn't look that big, but turns out that it's actually quite a few lives that you would prevent from dying from lung cancer or individuals. You see for California, at current uptake, you're about 3,000, projected for 3,000 deaths averted by 2050 due to screening. If you increase by 10% their current uptake, a tiny bit, you really need to go to 100% uptake to see a much larger, about 12,000 deaths that could be averted due to screening. For South Carolina, and current uptake is under 1,000. If you go to 100% uptake, which is unlikely, but it's possible, I guess, to get close, about 4,000. If you do then cessation on top of that, about, let's say, 1,000 more or so, maybe a little more, 6,000. So this just shows the benefit, but lung screening prevents lung cancer death. Cessation prevents many other deaths, premature deaths. So here is one measure of looking at that. Life years gained. There was some numbers shown before, life years gained. This similar calculation where you see actually, and let's just focus for South Carolina, how many deaths you would prevent under 100% uptake of screening by 2050. Sorry, not deaths, life years. These are in 100,000. So a lot of life years that you would gain thanks to screening if you were to screen everybody, but you see how those quadruple if you actually add cessation on top of screening, because then you will get all the benefits of all the other deaths that you would prevent. And we know that this is cost effective, so the question is, why are we not doing it more? Particularly in the scenario where we're saying that smoking is not coming down. So we need to have innovative methods, therapies, approaches to help people quit. This is one of them, as many others. Okay, so I think I'm close to my time. So in terms of conclusions, we can say that as we all know, but it's always good to see the numbers and see the value, the magnitude. Tobacco control in the U.S. has had major impact in reducing morbidity and mortality due to lung cancer, shown here, as well as other diseases. Current lack of decreases in smoking prevalence among adults is really concerning and calls for new approaches to tobacco cessation. the work that we do and U of SC is doing, and it's important to quantify things, so we're excited to hear more about the surveillance team work. Modeling projection helps state decision makers quantify the impact of existing and potential interventions, help decision making. And in particular, in the cases that we saw, to maximize the impact of screening for lung cancer, cessation interventions targeting that population are greatly needed. So with that in mind, I'll stop. Thanks for the organizer, my comments, and a big hand to all of you, because all those dates that I get to show and show off and doing my presentations is thanks to all the work that everyone here is doing. Thank you.
Questions for Dr. Meza? Oh.
So it's not a question, but it's just a comment for Dr. Meza. I think these are outstanding results from your study, and to provide it for South Carolina specific, that this couldn't be better timing, because as they are scrutinizing our projects and our funding at the federal level as well as at the state level, we really need to be able to show that impact. And not only are you showing lives saved now, but as you had indicated, it's so hard, but also the prediction on lives saved in the future. So thank you for this. I'm assuming that Smoke Free SC is going to have all the presentations online for us as kind of a follow-up, so we can pull out some of those data charts to share with those decision makers. Thank
Absolutely.
you.
Happy to share them. Yeah. Thank you.
Great. I have a question, a personal question, I guess. So my mother has lung cancer. She's been a lifelong smoker. And in her doctor's appointments, we've had not her oncologist, but the nurse practitioner we were seeing at the time tell her, because I asked about, smoking cessation and what we could do to encourage that. And the nurse practitioner told us that there are no effects in cessation and successive treatment. So how do you recommend, like if that's said to you in an appointment, how, politely, do I email her your studies, or how do I address that issue, I guess?
I'm not a cessation specialist. There's many here, and what I'll say is there's evidence that things that work. The data we show from the quit line is quite amazing. We have 40% cessation rates for those. I think other important data to share is that survival outcomes for cancer patients, not only lung but other cancers, are much higher if people quit. So we're starting to build some of that evidence. It's there, but I think we haven't really put it or highlighted as much. There's efforts from NCI to really do interventions of cessation for cancer patients, just because again it's a huge value. And sorry about your mom's diagnosis, but it's not only that improves survival, but also improves quality of life, which is the other thing. So I think that's what I would say. Yeah.
Thank you.
Yes, thank you. I am wondering two things. One, when we saw the quit line, we saw that for $1 spent, we saved $1.47. Is your team doing anything to calculate, dollars spent on screening and dollars that are beneficial in terms of a cost-benefit comparison?
Yeah, no, thank you for that question. We do, and we've published extensively on the cost effectiveness of lung screening. Under current guidelines and current costs, is cost effective. The point where now it's actually going to become more cost effective, because for lung cancer, the stage 3 and 4 advanced treatments, which are immunotherapies, are more and more expensive. So the benefit of early detection is going to be not only that patients live longer, but that they're going to avoid those expensive treatments. So it's becoming more cost effective as we speak. Okay. There are challenges with implementation. Family doctors are not necessarily embracing it. You have to assess back years. Clinicians feel that gets somewhat complicated. We're trying to work to figure out alternative ways to identify people who would benefit from screening that would make it the implementation easier. There's proposals to drop the package, just look at duration, and we have we have a paper on the review that looks at the impact of that and what are the trade-offs. So lots to do, but yeah, the cost-effectiveness argument is there. It's a question, of course, for each state, for each health program, affordability. Maybe one last thing I'll say is that it might look more expensive at the beginning, but centralized lung screening programs work much better than decentralized within each health system. One FTE, nurse navigator, can be the difference. Yeah, it's upfront cost, but long term, as was cited before, lots of savings.
And a little follow-up from the human side, has your team looked at, in epidemiology, we talk about quality life years. Can you talk at all about the quality life years that you're saving?
Yeah, no, we've done projections through the cost-effectiveness analysis account for quality-adjusted life years. A lot of the cost-effectiveness is based on the cost of the scan, and turns out that, of course, treatment and your quality of life during treatment is of course, diminished. Of course, early detection would benefit of that. During screening, there may be decreases to your quality of life while you're waiting for your result. You get worried if you get a positive result that turns out to be, ends up being a false positive, or maybe a too small nodule that is not concerning. There's some changes there, but in the end, the benefit is there. And we do account for it. We need to update our counts, but yeah, we do it.
All right. Thank you, Dr. Meza.
Thank you.